Induction and intubation of a critically ill patient is a high-risk activity. Preloading with fluids has been recommended to prevent critical hypotension. But does this work? We'll find out on this episode of Osler Short Cuts. Intubation in critically ill patients is known to be complicated by hypotension in a significant proportion of patients. Intravenous fluid boluses may counteract this problem by maximizing venous return. However, IV fluids are also associated with complications in this cohort. So does this practice help? The PREPARE-2 trial randomized 1,065 patients across 11 intensive care units in the U.S. It excluded patients in whom fluid boluses were definitely needed or definitely not needed. The study used an adaptive sample size technique where the proposed sample was adjusted based on the incident rate in the control arm, a very useful strategy in minimizing the risk of underpowering. Patients were randomized to either 500 milliliters bolus or standard care. Curiously, clinicians were not required to wait until the bolus was finished. So on average, patients in the intervention group only received 300 milliliters when induction was performed. Most of the patients were septic, and etomidate was the most common induction agent used. There was no difference in the primary outcome, which was a composite of death or cardiac arrest within 1 hour, and critical hypotension, or the need for new or increased vasopressors within 2 minutes of induction. The vast majority of events in the primary outcome due to the need for new or increased pressors. PREPARE-2 was a well-conducted pragmatic study exploring a commonly used practice. With a 40% overall mortality, the patients were clearly very sick. The results appear robust, and it does not appear that fluid loading as given in this study has any meaningful benefit. As always, there are some caveats. The study was unblinded. Given that the primary endpoint could be directly influenced by clinicians who were aware of the treatment allocation, there is a potential for bias. It must be noted that this study was performed in ICU patients and not in the emergency department. As such, most patients had already received some fluid resuscitation prior to enrollment. The volume of fluid given at induction was just 300 milliliters on average. Was this enough to generate a signal of effect? Furthermore, some studies suggest up to 50% of patients do not increase their cardiac output in response to fluid boluses. Perhaps some assessment of fluid responsiveness should have been used. Overall, the PREPARE-2 study is a well-conducted study that appears to suggest the practice of fluid boluses prior to intubation in critically ill patients does not help. Combined with the INTUBE study, this strategy has been found ineffective in 1,400 patients. If you liked this summary and would like to know more about the PREPARE-2 study and related subjects such as fluid responsiveness, head on over to Osler and check out the full review. Like all Osler content and features, it's completely free. See you next time on Osler Short Cuts.